I'm Monica Parker, a family physician and geriatric primary care provider. I began the practice of medicine in Georgia in 1991 in Walton County, Georgia, a rural setting 1 hour away from Atlanta. I've diversified my clinical work, and I now am a research investigator with the Goizueta Alzheimer's Disease Research Center at Emory University. My key role is to educate and inform the community about research studies such that volunteers can make an informed decision to participate in clinical research conducted here. As a clinician who moved to an academic setting, I observed that many patients in the geriatric clinic were actively participating in research for Parkinson's disease, memory loss, and sleep. They were receiving many evaluations that were not regularly covered by health insurance, including sleep studies, exercise treadmill tests, cholesterol screening, and memory screening. These evaluations, conducted through research, enabled many primary care disease prevention strategies for these patients. I also noticed that many of the research participants were not African American or poor. So I decided then that it was important for underserved and underrepresented patients to learn more about participation in research. Comorbidities are common among individuals living with Alzheimer's disease and related dementias. I work in Georgia, where over 50% of the Medicare or Medicaid beneficiaries with Alzheimer's disease and related dementias have more than 4 comorbid conditions. The 2 most frequent comorbidities for individuals with Alzheimer's disease and related dementias are hypertension and diabetes. But other comorbidities significantly associated with Alzheimer's disease and related dementias include cerebrovascular disease, Parkinson's disease, chronic skin ulcers, anxiety, and depression. The stroke belt is a region in the southeastern United States that has the high incidence of stroke and other forms of cardiovascular disease, especially among African American, Latinx, and rural populations. In the Framingham study, managing chronic diseases has resulted in reducing the prevalence of most vascular risk factors except for obesity and diabetes, and decreased the risk of dementia associated with stroke, atrial fibrillation, or heart failure. Social risk factors complicate the management of comorbidities and diagnosis, as well as the progression of Alzheimer's disease and related dementias. One major social risk factor is access to health care. Access to health care may be caused by a lack of qualified health resources in the community. These resources include having a nearby hospital and a pharmacy accessible by public transportation, and qualified healthcare providers that are culturally aware and linguistically similar. It's especially important for individuals to have an established relationship with a qualified healthcare provider or primary medical home. A medical home is where an individual sees a doctor for regular health checkups, medication review, and management of one's overall health. When there are changes in one's physical and cognitive status, the treating primary care physician is in a better position to order the appropriate test to ensure that treatable causes have been found and to make the necessary referrals for subspecialty care. My own mother is 95 years old. She had hypertension, diabetes, and obesity, and experienced many strokes for many years. Despite being an educated civil employee who has always had health insurance and access to comprehensive medical care, my mother had never received a comprehensive neurologic assessment for her memory deficits. I associate this with the healthcare provider's inexperience with dementia. It was only when she participated in a clinical research study where she had both an MRI and a lumbar puncture that she was diagnosed with a mixed vascular and Alzheimer's dementia. However, depending on the research study, persons with uncontrolled chronic diseases may not meet eligibility criteria to participate in clinical research. This can be a barrier to participation for persons in underserved or underrepresented populations with comorbid conditions. Improving the lives of individuals with Alzheimer's disease and related dementias requires both systemic and individual action. I'll highlight a few of the potential examples. There are systems in place for underrepresented and underserved individuals to improve access to health care. Federally funded community health centers, public health departments, and non-governmental or nonprofit organizations such as the Good Samaritan Health Center in Atlanta provide care for poor and underinsured individuals. Federally funded community health centers provide full-service care, including medical and dental care in both rural and urban areas. They're a valuable resource for an individual who does not have an access to a private practice doctor. Federally funded community health centers also serve a large segment of the underrepresented and underserved populations, which include Native Americans. At the Good Samaritan Health Center in Atlanta, most of the staffers are of South American heritage and converse with the patients in their preferred languages, which may assist patients who would otherwise face linguistic and cultural challenges. To further close the gap for underrepresented and underserved individuals, the medical workforce shortages must be addressed. We must train and expand existing workforce in geriatric care to serve our aging population. Pharmacists, advanced practice nurses, and physicians are a critical need. More medical students must be trained in primary and dementia care. Medical providers must be representative of the communities they will work in. There must be ongoing educational initiatives to be undertaken in medical schools, but also governmental incentives that fund medical education and training. Education and cultural awareness training can also help with improving medical care for these populations. We should regularly implement the annual wellness visit, which is covered by Medicare, to address and screen for comorbid conditions and treatable illnesses in persons aged 65 years or older. A dementia and a depression screen are part of this examination. Healthcare providers can also empower patients to take specific actions to reduce their chances of developing Alzheimer's disease and related dementias and improve their quality of life. According to the 2020 Lancet Consensus Report on Dementia, we may encourage an individual to 1. Exercise regularly, maintain a healthy weight, consume a healthy brain diet, screen for and manage depression, manage chronic diseases such as diabetes, hypertension, and heart disease, remain socially engaged and prevent social isolation, manage hearing loss, manage sleep disorders, and stop smoking. As healthcare providers, we should be aware of the unique characteristics of the people in the communities we serve. We should understand their individual care needs as holistically as we can, and also the needs of their caregivers.